So good morning, everyone. It's 8:30 and we will start on time. I'm Luc Veliquet. I will chair the beginning of the session because Dr. Tanguay and Hammerer are in the General Assembly of the SIU and they should come here right after. The first speaker this morning, we are privileged to have Professor Roger Maszalski of the Department of Urology, Vanderbilt University, USA. He's a well-known contributor in the field of functional urology. He's the editor-in-chief of Neurology and Neurodynamics, and he has many accomplishments. His current research interests are outcomes of incontinence therapy with a particular emphasis of quality of life issue, and is also active in biomaterials evaluation. So I welcome Dr. Maszalski.
Good morning. It's a great pleasure to be in Seoul and to be speaking with the SIU. Today we've been charged with giving you an overview of select topics within the domain of functional urology. So I will introduce the various faculty. We will sequentially move through the lectures, which will take between 12 and 15 minutes. And then with whatever time we have left, we'll have a brief discussion period. These are my conflicts. I am on the American Board of Urology. The first lecturer will be Professor Chris Chappell. Chris is a dear friend. He'll speak on the detrusor muscle and whether or not it should be the target for lower urinary tract symptoms. Chris is a consultant urologic surgeon at Sheffield and in the UK. He's also honorary professor at the University of Sheffield and visiting professor at Sheffield Hallam University, and he's also, of course, Secretary General of the EAU. The second lecture will be given by John Hessekers. John will give a lecture on external sphincter behavior and spinal cord injury, dysfunctional voiding, and pelvic floor weakness, a certainly very easy topic. John is a attending urologic consultant at Radboud University in Nijmegen in the Netherlands. And finally, Alan Wien will give a lecture on nocturia, a brief update and an overview of the condition. Alan is founding professor and emeritus chief of urology, and he's also director of the urologic training program at the University of Pennsylvania at the Perelman School of Medicine in Philadelphia. So without further ado, Chris?
Professor Domakowski, Professor Veliquet, thank you very much indeed for kindly inviting me to speak at this meeting. And I'm very honored to be here at the SIU meeting in Seoul. You've given me the challenging topic about what is a target for therapy. And in this context, I'm just going to try and give you some views that I have held for a number of years relating to this. In terms of my conflicts, if this thing will work, which it does, those are my conflicts which are relevant in the context of this discussion. I'm going to review for you the relevance of the lower urinary tract relating to symptomatology, aspects of the innovation, and how the various therapies work in this context. The first thing to remember is that we're dealing with lower urinary tract symptoms, and these are not disease-specific, and in this context, patients will often report them in different ways depending on their individual biases. We also have our biases in the way we interpret these symptoms. As urologists, we love to talk about syndromes, but we have to look behind what we're talking about in considering this. This question was first raised by Paul Abrams a number of years ago, who coined the term lower urinary tract symptoms, which actually brought together thoughts from a number of workers in the field relating to this. In other words, that we're dealing with storage, voiding, and post-micturition symptoms. In the context of the overactive bladder, I'm talking about storage symptoms. And we mustn't forget, and this just emphasizes the point that the bladder is an unreliable witness, that the symptoms we see, whether storage, voiding, or post-micturition, are really equally distributed across the male and female population, which raises the point that if you like to think it's the prostate causing the problem, then you may be missing the point. In this context, if we're talking about overactive bladder, which Alan Wien was one of the pioneers who described, then certainly what we're talking about is storage disorder, which is based on a sensory symptom urgency. This leads on to reduced intervoid interval, and in a third of female patients may result in incontinence. It can also be responsible for nocturia. We'll hear more about that from Professor Wien later. And obviously, if you're going more often, you'll void less. It's very clear that this is a symptom complex that increases with age in both men and women. And we do know in modern practice that you cannot practice modern urology in men or women without using a bladder diary. You can't define nocturia. You can't define the voiding problems. You cannot define the storage problems or assess whether there's too much fluid intake. So what are we talking about? Clearly, urgency is a sensory symptom. It's difficult to define, it's difficult to explain to people, and it's quite distinct from the normal urge. We do have a problem in the literature with the term urge incontinence, which of course is a misnomer, but based on a regulatory bias in North America. And if you look at the male patient, although we love to talk about BPH, it is a histological problem, and what we're actually talking about is lower tract symptoms in an aging male, often storage symptoms, which are what bring men to see us. Voiding, of course, leads to retention in only 0.5% of men with significant symptoms over a 5-year period. So it's overactive bladder storage symptoms which are a problem, but of course we're dealing with a complex situation where there are many other factors in the intact human which actually relate to symptomatology. So we're talking about a symptom complex quite distinct from a urodynamic detruse overactivity. Now, many people think the two are similar. Well, of course, the overactive bladder may be due to detruse overactivity, but if you look at the literature, we know we're dealing with a functional problem. And of course, the detrusor muscle may be a target, but is it? If you actually look at the literature, very clearly in women, even if they've got incontinence, only 60% have detruse overactivity. In men, of course, it's 90%. So overactive bladder and detruse overactivity are clearly not the same thing. Now, if you go back to history, of course, we're all familiar with deadly nightshade and belladonna. And if you look, this is something I pulled yesterday off the internet, Mr. Google. We all think the detrusor muscle is the target. But do we? If you look at muscle strips, of course, we know that an anticholinergic will inhibit normal neurotransmission through acetylcholine. But if you look in more detail at the literature, it's very clear that there are cholinergic receptors, not just in the detrusor muscle, but on the urothelium, on the sensory nerves, and of course the interstitial cells in the bladder. So is the detrusor muscle the target? Well, of course, if we accept the fact that only 50% of women, at the most, have detruse overactivity, and urgency is a sensory symptom, is it the detrusor that's a target in women? Is it the detrusor that's a target in men? Because if you actually target the detrusor in men, you may, of course, lead to problems with retention. We all know if you give enough of an anticholinergic, you'll produce that in most men. So, when we're looking at antimuscarinics, we know they affect muscarinic receptors. We know that they can cause retention, but the detrusor probably isn't the target. It's a bystander effect in most patients. And of course, if you look into the literature, this is a paper from 10 years ago, where we reviewed the literature, and you can see Karl-Erik Andersen and many others, Roger Domakowski, and we looked into the literature in detail there. We also know that there's crosstalk based on the neural innervation between the bladder and the rectum. And of course, this is another factor which explains why there's often symptomatology in the bladder with rectal disorders. If you look at the actual anatomy, the microstructure of the bladder, it's quite complex. And this is why we can't bioengineer bladders. And injecting cells in the bladder, of course, is also unlikely to be the solution, because it's a very complex environment with a urothelium which has got a metabolic rate 4 times that of the detrusor muscle, and where you actually have this complex innervation with the interstitial cells, where the detrusor, of course, from the Latin detrudare, to drive out, is an important factor in emptying the bladder, of course, but it's only part of the picture. And this has been emphasized by work you can see summarized here by Karl-Erik Andersen, where we have non-neuronal release of neurotransmitters, including, for instance, nitric oxide. And it's scavenging of that by blood clot that leads to clot retention, so-called. Of course, the detrusor muscle is essential. If you haven't got a detrusor muscle, you'll end up with a bladder that won't work. But it's a suburothelial space, I would suggest to you, which is a target for much of our therapy, where you have the interstitial cells and, of course, the cholinergic receptors on these sensory nerves which lie just below the urothelium. And indeed, if you look at this diagrammatically, although it looks quite complex, and is certainly, there's good now evidence that you can see here, looking at the interstitial cells from Karen McCluskey in Northern Ireland, who's done a lot of work on this, that they actually can be stimulated directly by acetylcholine. And these are the main integrating cells in function of the bladder. So it is probably too limiting just to focus on the bladder, isn't it? We all realize as we're sitting here that if you think about it, you can sense whether your bladder is full or if it's filling. And so let's look peripherally. Of course, sensations go from the bladder up the periaqueductal grey matter, and they reach the limbic system, the emotional centers. That's why stress, anxiety will often lead to urinary frequency. And in this context, whilst you're sitting there, this is what's happening. You're getting an inhibition by the limbic system on the pontine micturition center, which automatically is always trying to contract to make the bladder work. And of course, when you give permission to void, you release that inhibition of the pontine micturition center, which will lead to the bladder emptying, and that's been very clearly shown by MRI-related studies, functional studies, which have looked into this. But we still don't understand the picture completely. Why is it in painful bladder syndrome, bladder pain syndrome, interstitial cystitis, if you like, that you have a different sensation, which is pain, quite distinct from urgency, although there is overlap between the two. So there's a lot yet to be discovered. Unfortunately, the animal studies haven't helped. There is not a single drug that's been developed for the function or dysfunction of the bladder that has ever come out of any of these studies. And that is because you're dealing with a non-cholinergic innovation, and you're dealing with usually an adolescent animal where you're actually not looking at the effects of aging. So clearly, there are a lot of targets going from the CNS right through to the periphery. And often one can talk and hear this at meetings, symposia, particularly where drugs are being discussed, where castles are built in the air. So let's look at some facts. We know that there is a class of compounds which actually target the vanilloid receptors and the sensory nerves. We know these, chili, for instance, and you can see here that two agents, capsaicin and ricinovitoxin, are extremely potent in this context. They're derived from products, from plant products, and we know they have no effect on the detrusor directly, but if you put them in the bladder, they can cause retention for 6 months, just by stopping the sensory nerves working. We know that if you look at the PD5 inhibitors, for instance, that it's clearly been demonstrated, for instance, in a head-to-head study in Europe, that the tadalafil is more effective on the symptoms than, for instance, an alpha blocker. And this is acting, of course, as we know, and the meta-analysis in the world literature demonstrates this, on sensory-type mechanisms, as well as probably blood flow and other potential aspects. And of course, there are a number of theories, and when you see a lot of theories, it means we really don't fully understand how it's working. But there's no evidence it's working directly on the detrusor muscle. So I pulled another slide off the internet, because if you look at what the regulatory authorities say, they say that the beta-3 relaxes the bladder. But how does it relax the bladder without increasing residuals? So it's a misnomer, if you like. It relaxes the bladder by the afferent mechanisms which we've discussed. And of course, this is the sort of slide you see on the internet. And if you look in detail, it acts on adenylyl cyclase, and there's now good evidence it's working on these sensory mechanisms. And indeed, if you look at the adverse events, it doesn't affect the cholinergic system, but has similar effects, for instance, to an anticholinergic, and we know that. It also doesn't cause retention. So let's move on to tertiary therapies, botulinum toxin and sacral neuromodulation. Of course, I'd like to acknowledge Rick Schmidt, who worked with Tanago both on sacral neuromodulation, but also who took out the patent on botulinum toxin when he was in Denver. We know that from acupuncture, from Chinese medicine, that affecting sensory nerves will affect bladder behavior, posterior tibial nerve stimulation. Don't tell me for one moment this is acting directly on the detrusor muscle. Are you telling me that sacral neuromodulation is acting directly on the detrusor muscle, or is it acting on the sensory nerves? And if you look at the patent for botulinum toxin, although we all hear about the theories about release of acetylcholine, there's all good evidence in literature. There's also affects release of the putative sensory neuropeptides. Work from our group has clearly shown a direct effect on the sensory mechanisms using a preparation, an annual preparation admittedly, but looking at sensory traffic, where botulinum toxin drops us down. And here's a paper from Roger Domikowski, which I was involved in a number of years ago, a phase 2 study looking at botulinum toxin. Let's look at the dose-response characteristic. As you increase the dose of botulinum toxin, you have a plateau at around 100 to 150 mouse units. As you know, they're not international units, they're mouse units. The LD50 for mice is a unit of botulinum toxin. And you can see here, if you increase the dose beyond that threshold, you just increase retention. You don't improve efficacy. So if you like, I've shown for you, I hope, compelling evidence that the target is the sensory system. There is a bystander effect on the detrusor muscle, without doubt. But is that the target? It's up to you to decide. If you look at trying to look at biomarkers, there's been little good evidence for this. There was a lot of enthusiasm for NGF until the shrink study demonstrated there wasn't any NGF measurable in the bladder, and all those papers have now disappeared. Bladder wall thickness is probably a marker of detrusor overactivity, but it's difficult because you're dealing with millimeters. So at the end of the day, we still have to look to the future. And I welcome you to the AU meeting in Barcelona next year, which I hope you'll put in your diaries, where we'll continue this debate and discussion, which has been started at many meetings, such as this excellent meeting here. So thank you very much for your attention.
Chris. John?
Thank you very much for the invitation. Welcome to you all here in Korea. I'm going to talk about sphincter behavior in a couple of diseases like spinal cord injury, dysfunctional voiding, and pelvic floor weakness, which are quite different topics and not easy to combine. If you look at spinal cord injury, you have to realize that quite a lot of these spinal cord injuries are incomplete. If you have an A lesion, that means that you have a complete lesion that has a lot of effect on the sphincter. And if you have an E lesion, you have a very incomplete lesion, and that most likely doesn't have that much effect on the sphincter. So that's the first thing you have to know. On the other hand, also, if you have a high spinal cord injury lesion as compared to a low spinal cord injury lesion, then the difference of the sphincter is very different. A high spinal cord lesion, like an upper motor neuron lesion, most likely has an overactive sphincter, and a low motor neuron lesion has an underactive sphincter. So there's quite some difference there, and you have to realize that not every spinal cord injury has the same behavior of the sphincter. If you look at the suprasacral lesions, those are the ones that have the upper motor neuron lesions, about 96% do have detrusor external sphincter dyskinesia, and that's very important because the higher lesions are the most important, and we all know that they have quite some effect on the sphincter in a negative way, and you have to deal with that. If you look at this slide, you can see how detrusor external sphincter looks like. This is the detrusor pressure. You can see it here. If you look at the flow in this region, you can see that the flow is very low. So the detrusor pressure is very high, flow is very low. That means something is wrong with voiding. Can be the prostate, but most likely in spinal cord injury patients, it is the sphincter. And you see that in the bottom line where the EMG recording is depicted. This one really is a very overactive sphincter, and this really is a good sign of detrusor external sphincter dyssynergia. There's also detrusor internal sphincter dyssynergia. Those are very circumscript lesions located somewhere at low thoracic, high lumbar lesion, and that means that the bladder neck is closing. If you do video urodynamics, you can see here, for instance, that if you combine the pressure with the picture, that the bladder is closed at bladder neck lesion, not at the sphincter lesion, which is down under the prostate. And this really is a good example of detrusor internal sphincter dyssynergia. If we come to dysfunctional voiding, well, what exactly is it? Well, it is mostly left from what is not neurogenic, I must say. And it really means that there is an inability to fully relax the urinary sphincter during voiding. We don't have any neurogenic cause for that defined. And it can be present with incontinence, it can be present with urinary tract infections and constipation. So it's quite a complex situation that is seen quite often in children. If you look at the flow, it's an intermittent flow. It has a fluctuating pattern, and you can call it also a staccato flow. What is the cause of this? Well, we think that detrusor overactivity can lead to overactivity of the pelvic floor itself with insufficient relaxation during voiding. And that may be learned or learned in a bad way during toileting training years, and that can be caused due to urinary tract infection, constipation, or secondary even to sexual abuse. Also, environment, like poor toilet conditions, can trigger this bad voiding, and it really means that the ones that are trying to go to the toilet don't do that in a very proper way while contracting the bladder. They should relax the pelvic floor, and that's quite often not the case. And some anatomical condition can also be prevalent in these children. How do we define this? How do we diagnose this? Well, you can do it with free uroflow. We have urinary tests, of course, to find out whether there's a urinary tract infection. You have to make some ultrasound of the kidneys and the lower urinary tract in order to find out whether there are still already other dysbehaviors. And that can be combined with urodynamic investigations, cystoscopies, and micturition cystographies. And these are examples of how it can be. On the top level, on the left, those are the good flows, a very nice flow with a good curve and a nice shape of the curve. If you look at the two buns on the bottom, you can see that it's a structured curve. It means that there is not a lot of dynamicism in these flows. The flows is very poor, and it stays that way. And if you go to the right side, you see there are some dynamic obstructions. Sometimes it's good, sometimes it's bad, and these really are good examples of dysfunctional voiding. If you combine that with cystography, this is what you can see. You see a trabeculated bladder here, and you can also see that the bladder neck is open, and at sphincter level, the bladder is closed, which can be a cause of dysfunctional voiding when it's a non-neurogenic case, because you have to realize that those two have to be separated from each other. And the voiding pattern goes like this. Goes up and down again, meaning that sphincter behavior is too active during voiding at some moments, and this is called a dynamic obstruction. If you do urodynamics with it, you can see that there's quite some straining of the abdominal muscles in order to void, although the flow is poor, and that is caused by poor sphincter, and this is another example of this. If we come to pelvic floor weakness, well, then we quite often talk about stress incontinence, and you have to realize that that can be caused by a couple of things. The most severe one is caused by pure intrinsic sphincter deficiency, ISD, where the urethra is bad by whatever reason. Can be radiotherapy, can be an imbalance of metabolism, it can be some kind of embryological disease. But most of the time, it is the combination of a hypomobile urethra, in women that is, combined with intrinsic sphincter deficiency. Most women do have hypomobility, and not all of them are incontinent, of course. That means that you have to have some degree of intrinsic sphincter deficiency to really have stress incontinence. And how does the sphincter behave there? Well, you can have a pelvic floor weak situation with an adequate sphincter, and also when the sphincter is weak. If you want to diagnose that, so you want to know whether your sphincter is inaccurate or not, then you can look at urodynamic investigations again, like urethral pressure profilometry, that gives you the maximal urethral closing pressure. You can also diagnose that with Valsalva or Cough leak point pressures. And if you have a low maximal urethral closing pressure, or a low Valsalva leak point pressure, or a low Cough leak point pressure, then you can define intrinsic sphincter deficiency, and then you know that your sphincter is weak. So how that is done in clinical practice, depending a bit on what area of the world you live in. This is urethral pressure profilometry. You do the pulling diagnostics in a quiet bladder, so the patient is doing nothing at this moment. And what you can clearly see here, that if you pull the sensor through the urethra, that the pressure goes up to this level and then goes down again. This is really an example of a good sphincter. If you look at the maximum urethral closing pressure here, it's about 80 centimeter of pressure. If you are above 20 or above 30, then most of the time you are okay. That's what we think by convention. If you look at this situation, well, you also have a closing pressure here. That's a bit less, it's about 29 centimeters of water, and you can imagine that this sphincter is not that good. So this is what you can do with urethral closing profilometry in order to find out whether your sphincter is doing well or not. You can also do that with leak-borne pressure, and the big advantage of this is that you don't have to use the catheter in order to find out whether that's possible. You only have to look at the pressure in the urethra, and it can register the leak. For instance, if you strain Valsalva leak-borne pressure, you can imagine that at the moment that the pressure, that the urethra starts leaking, so at the beginning, you look at the detrusor or the intravesical pressure, and you have your Valsalva leak-borne pressure defined there. You can also do that with cough, but it's a bit more difficult because you can imagine that all these very steep cough spikes don't make it very easy to register the proper leak-borne pressure, but you can do it as well. But you can have to tell me whether this is the cough leak-borne pressure or this one, because it's very difficult to distinguish the two. So in conclusion, yes, the sphincter can be overactive. That is mostly in neurogenic patients when there is detrusor external sphincter dyssynergia, high and complete lesions. And if you have a non-neurogenic bladder, then you have dysfunctional voiding with the same effect. If the sphincter is underactive, that can be caused by intrinsic sphincter deficiency, but you can diagnose with low maximal urethral closure pressure or low Valsalva or cough leak-borne pressure. Thanks very much.
Thank you, John. Alan?
Good morning, and thank you for the opportunity of addressing this plenary session. These are my potential disclosures. I think everyone in this audience knows what the International Continence Society definition of nocturia is: waking at night one or more times to void, each void preceded and followed by sleep. I think everyone knows how to measure that, counting the first void in the morning as a part of the nocturnal urine volume. I think the issues basically with nocturia are these. I think it's understudied, it's undersought after and under-recognized as a real standalone problem. It's not a natural part of aging. It's not just a problem in the elderly. It's not just due to overactive bladder in women or benign prostatic obstruction in men. And it does have significant adverse effects on the quality and, you'll see, quantity of life. So these are the questions that I'll try to discuss. Why does it occur? When does it become bothersome? Why is it important? When is the waking episode most bothersome and harmful? How common is it? What are the contributing factors and causes? And how is it managed? So having to get up at night to urinate is a product, very simply, of the relationship between the amount of urine that's produced at night and the ability of the bladder to store urine. And the ability of the bladder to store urine depends on maintaining a low pressure inside the bladder, normal sensation, no detrusor overactivity, adequate sphincter function, adequate bladder capacity with near complete emptying, and no excess urine production. When does it become bothersome? I think everyone would agree that one time generally is not bothersome, although it can be, and a high-powered executive who've never gotten up at night, 50 years old, and all of a sudden once, and it's bothersome. But most people would agree that 2 or more times at night, basically, it does become a significant bother. And in fact, Chris Chappell, in a summation of an expert consensus meeting, has summarized a lot of the literature saying that nocturia is the most bothersome symptom in patients with lower urinary tract symptoms and BPH, and has a significant effect on the quality of life. What's the most important part of sleep? Well, deep, slow-wave restorative sleep occurs during the first hours of sleep, while the less restorative sleep occurs later. So waking up during the first 3 to 4 hours is apt to leave you more tired and groggy the next day. So the first uninterrupted sleep period, therefore, is a very important outcome indicator in all studies that are related to the management of nocturia. Now, nocturia is associated with a lot of negative factors. I say associated because to prove cause and effect is difficult. This is some of the older literature: reduced health quality of life, increased mood disturbances, reduced work productivity, increased falls and fractures, which has been around a long time, poorer overall health, and actually increase morbidity. The short-term consequences, again, summarized by Paul Abrams and Chris Chappell, can be summarized as increased daytime sleepiness, reduced alertness, longer reaction time, decreased daytime energy, reduced psychomotor performance, decreased concentration, memory, and cognitive function, and just a poor mood. The long-term consequences, depression, increased susceptibility to all types of somatic disease, cardiovascular, car accidents, falls and fractures, and mortality. Now, this doesn't just come from the medical literature or from the pharma industries. This is a very interesting short book that I'd encourage you to read. It's by a non-pharma, non-medical person who's a professor of neuroscience and neuropsychology at the University of California at Berkeley, who's been interested in sleep for a long time. And I've simply tabularized what Matthew Walker lists in his book as those problems that are increased and those factors that are decreased, which are negative factors, in fact. So take a look at this list. And these are basically documented in the book. And if you look at this list, you can say, you know, this is a problem in and of itself. And this is just a quote from the book that no aspect of your body is left unscathed by sleep deprivation. Now, because of the often serious systematic disease or systemic diseases that are associated with nocturia, you might expect that mortality would be increased. But if you do a study where you exclude all comorbidities, you find, surprisingly enough, that basically nocturia is associated with increased mortality. And this is not just one study, this is many studies. And the more times your sleep is disturbed at night on a consistent basis, the more likely you are to die within a certain period of time. So it's pretty incredible if you look up this literature for people who consistently get up 2 or more times at night. It affects daytime activity and work productivity. How common is it? If you look at the 2 upper bars, and it's similar in men and women, you see that it's very prevalent, 2 or more episodes, actually even in the 45 to 55 year category, and it simply goes up after that. What's the etiology? Well, I think that you can summarize it fairly quickly, and you can do this as well as I. Sleep disturbances, psychological factors, bladder storage problems, OAB, polyuria divided into 24-hour polyuria and nocturnal polyuria. And of course, most cases are not isolated, but most cases are a mix of some of these. So using the 33% definition of nocturnal polyuria, that is the amount of urine made from the time you intend to go to sleep until the time you wake up in the morning, what percent of people that have nocturia twice or more do you think have nocturnal polyuria? Well, surprisingly, you know, it's around 80% or over, which is pretty surprising. How do you evaluate nocturia? Well, I think the first thing you do is identify clearly relevant medical causes that can be treated by mechanism-specific approaches. And I think these are the big 4: poorly controlled diabetes, congestive failure, peripheral edema, sleep apnea, and also you can add to this uncontrolled hypertension. And of course, we evaluate people for overactive bladder and benign prostatic hypertrophy. Now, I think these folks also should be evaluated for nocturnal polyuria, and the question is, when exactly do you do this in the evaluation? After all the conventional therapies have failed, or do you do it up front, and how do you do it? Because most people regard a 3-day, 24-hour diary as a pain in the neck. I think that's maybe a subject for next year's meeting. Management, well, behavioral management is important. The question is, how well does it work and how long does it last? The quick medical hits, treating overactive bladder, treating BPH, and usually last on the list is treating nocturnal polyuria. What are the outcome indicators? Well, the number of times you get up at night and the time to first awakening, that first uninterrupted sleep period. Quality of life indicators, and there aren't many or any validated quality of life indicators for nocturia except for a new one called the Into. Now, basically what we don't have is we don't have a long-term decrease in adverse events that would lead you to the definite conclusion that these are responsible, that nocturia is responsible for these events, and when you ameliorate that, you also decrease these events. However, it's pretty clear that improving nocturia improves quality of life. So what are the behavioral and lifestyle modifications? These are the things we all do. Urinate before you go to bed, try and decrease the amount of fluid the late afternoon and early evening, try not to take in too much caffeine or alcohol before bedtime. If you're on a diuretic in the morning, maybe move it to the afternoon to try to get some of the fluid off. Compression stockings, and if you have peripheral edema, elevate the lower extremities around 5 or 6 o'clock. For medical management, these are basically the things that we mentioned before that you can do to try to control these. Sleep apnea is something that's very important and often overlooked. And to decrease nocturia, if you look at it in a very simple way, I mean, these are the only 3 ways to do it. You can decrease bladder activation, as Chris was mentioning, whether you think it occurs in the bladder or higher up in the central nervous system. You can decrease the amount of significant residual urine and thereby improve nocturnal storage capacity, or you can decrease nocturnal urine production. So I think that you should target the most prominent symptom or set of symptoms first, and in many cases it will be overactive bladder or prostatic enlargement or obstruction, but don't forget about nocturnal polyuria if these don't work. Now, these are statements made by the European Association of Urology Guidelines Committee. Look at the second bullet. Data on overactive bladder medications generally had a female predominant population, true, but were not significantly better than placebo in decreasing nocturia, and we assume that this would also apply to the male-only populations, and in fact, it does. So the overactive bladder medications don't work very well. The alpha blockers don't work very well on nocturia. So basically, these are some facts that these remedies to treat things that we urologists treat most often don't adequately address nocturia, and the reason is because they don't adequately address nocturnal polyuria. So the improvement in nocturia is very often minimal with those therapies, and the only way to treat that would be, after you failed with those, to use desmopressin. Desmopressin is endorsed by both the ICS and the EAU with the highest level of recommendation. So here's a question that maybe is suitable for next year's meeting, because you could spend an hour on this. Is desmopressin dangerous? The reason that most people don't use it, at least in the United States, is because they think that it is dangerous. Is it? I don't think it is if you use it properly. What about adding on therapy? Suppose you fail with BPH, but you've treated the daytime symptoms, not the nighttime symptoms. Similarly, with overactive bladder, is it okay to add desmopressin to these therapies? Well, the mechanism of action is different, and it's quite specific for decreasing urine production. So there's no reason to expect anything other than a similar effect in these populations. So what's a summary of the way forward? Well, first of all, recognition that nocturia twice or more on a consistent basis is a standalone problem that's associated with considerable morbidity and negative occupational, social, and quality of life effects. I think we need to find general agreement on a simple algorithm, not terribly complicated, because I don't think this is rocket science. And finally, studies aimed at showing what I call a reverse parallel variation between a reduction in nocturia on a consistent basis and a reduction in the adverse associations cited previously. Thank you.
Thank you, Ellen. So a couple of brief questions. We have about 10 minutes. So Chris, wonderful summary of bladder sensation, afferent behaviors and whatnot. Thoughts about the potential role in the future, specifically related to bladder sensation and stem cell therapy?
Thank you, Roger. I think this is a very topical issue at present. It's a very sexy topic, tissue engineering. I think the question you always have to ask is, if you're injecting a cell, what type of cell are you injecting? Injecting it into a very complex neuropharmacological picture, as I've mentioned. And then the question is, can you actually functionally innovate these cells? So even if they can grow, which has been shown in animal studies, can they pick up an innovation in the bladder? Yes. In the urethra, yes. But in many women with stress incontinence, they have a denervation. And even if they then pick up an innovation, can these cells function in a coordinated fashion with a coordinated neural response? So in the urethra, will these relax when you want to void? And in the bladder, will they contract when you want to empty the bladder? These are questions that I haven't seen asked before people have rushed into doing studies with these therapies. Thank you.
Thank you, Chris. John, very nice summary of the complexities of dealing with the outlet, especially in the neurogenic patient. Assuming a spinal cord injured patient in the chronic phase, what is your preferred method in the complete patient for lower urinary tract management? Are you a sphincter ablator or are you a storage emphasizer?
I would be a storage emphasizer. If you can circumvent the behavior of the sphincter, then I think you're well off here. And it's not easy. You can cut it, but then you are completely incontinent. If you are able to use this sphincter misbehavior in another way, and that mostly means self-catheterization, then you can get rid of it. You can also do very extensive surgery, but that is not for everyone, and I think it's not always very good for the patient as well. So cutting the sphincter, no, that's not the way to go. I think you should try to circumvent it.
Thank you, John. Alan, as usual, an excellent summary of the condition. Thoughts about multiple factor treatment in the patient with nocturia. In other words, you mentioned quite a few chronic diseases that certainly present as comorbidities. Are you a sequential treater, or do you believe it's reasonable to group therapies for the individual in terms of optimizing effect?
I'm a little of both. I think that everyone deserves a trial at what I showed as behavioral modification. I'm not sure that it's going to affect it very much. And I think that you need to treat the predominant symptoms first. If they have mostly daytime symptoms and you think they have overactive bladder, I mean, have a go at it. It doesn't hurt, and you'll be able to tell within a relatively short period of time whether it's effective. And it's similarly with someone that has BPH. But if that doesn't work and they still get up 2 or more times at night and it's bothersome to them, or if they get up 3 or 4 times a night and they say, you know, it doesn't bother me at all, well, it actually does bother them, but unfortunately they can't see it until it's later in life and it's too late. So I think sequentially, I don't think anyone should change their treatment and treat everyone that comes in that gets up 3 times at night with a desmopressin preparation initially. I don't think that at all. But I think that it is a modality of therapy that many of us are scared of and don't use to its optimal effect. But I think that you should use it if someone comes in and they say, you know, what bothers me really is I get up 4 times a night, I'm fine during the day, then yeah, I think it's perfectly reasonable to use it first. It obviously is going to work best in those patients that have nocturnal polyuria. And in fact, if you read the indications, that's the indication both in Europe and in the US and worldwide. But you know, I like to do it sequentially so I don't violate any urologic tenets and I don't overlook an easy hit.
Alan, you also mentioned issues associated with fluid metabolism and potential drug effects with some of the active agents. Can you just comment on sort of the recent learnings of just fluid and water metabolism in terms of what we've seen in even placebo groups from hyponatremia?
Yeah, in all of the studies, and I think this is what you ask, in all the studies on nocturia, there's an incredible placebo effect. And what's the placebo effect due to? Well, if you measure urine output overnight, which everyone does in these studies now, you'll see that the urine output goes down in the placebo group. And if you use urine output as a surrogate for liquid in, then the inescapable conclusion is that these people do exhibit some behavioral modification in the placebo group. So the trick is just proving that whatever preparation you're using is statistically more effective than the placebo group. Is that what you were?
Yeah. Chris, you've done a lot of deep thinking about the placebo effect in functional urology. Make a comment, if you will, regarding the value or lack thereof of diaries and sort of the modulation of behavior associated with same.
Roger, thanks. I think you raise a very good point, which you have emphasized in the literature, and that's that all the trials that we look at, which we use to reflect routine clinical practice, are based on patients who are using bladder diaries. And a recent study, which you were involved in, when we did an analysis of this, we demonstrated that in the placebo group, they reduced their fluid intake, and in the active treatment group, they increased their fluid intake. The other salutary factor is that in routine practice, present company excluded, of course, most people don't use bladder diaries. So when you're taking randomized controlled trials where everybody's used a bladder diary and relating it to clinical practice, you can see a problem. Secondly, talking about nocturia, none of the studies have used the bladder diary to exclude people with nocturnal polyuria, for instance, with alpha blockers. So when we actually look at the literature, it's not surprising that you don't see an effect, because there will be nocturnal polyuria, as Alan has mentioned. So I think we have to just bear in mind the mismatch between the so-called evidence base and clinical practice.
Well, John, last question. You're truly one of the world thought leaders in neuromodulation, and I believe in Holland and certainly in other countries in Europe, you have a different stimulator than is available in the U.S., which of course is the Brindley stimulator. And wondered what your thoughts are about modifying pelvic floor behavior in the spinal cord patient with neuromodulation, and is that a potential? Is it possible? Is it ridiculous to even think that neuromodulation may have a role?
I think it's very intriguing. Well, you have neuromodulation, neurostimulation. If you talk about stimulation, it really means that you go into the pure innervation of the lower urinary tract by cutting dorsal roots, stimulating anterior roots. That's possible. That's not done a lot worldwide, but it's very effective. I think it is not for every clinic because it's quite complex. If you talk about neuromodulation, that's more intriguing because it really means that you try to re-educate the innervation system that is left after spinal cord injury, or that you try to reinforce the curing capabilities. And we always thought that it is not possible to do that if you have a complete spinal cord transaction, because it doesn't give you the possibility to act with the nerves. But some studies say it's different, and that it is possible to correct if you are in a very quick way there. So directly after the spinal cord injury, if you then do something with the nerves that perhaps might restore to some extent the function or preserve the function of the lower urinary tract. That's intriguing, but we're not there yet, and I think we need a lot of studies in order to find it out.
So I'd like to thank the panel. This is a rare coalition of some of the finest minds in functional urology. You've heard new thoughts about afferent mechanisms, also the complex management of spinal cord injury and detrusor sphincter behavior, and obviously the onset now or the recognition and evaluation and the importance of evaluation of the relatively newly appreciated condition of nocturia. Thank you very much.